So as we described in our initial presentation, we believe we have a really unique opportunity to fundamentally transform the way joint replacement care is provided from beginning to end and have CJR recognized as one of the premier centers in the country. We are hoping to really distinguish CJR as a national leader in arthroplasty, but also as a pioneer in personalized medicine. So in our last meeting, we told you what our vision was, and now we have more details and are able to answer any specific questions that you all may have.
Okay.
So before, I'm sure the group is well aware of the changes that have occurred starting April 1st. But before April 1st, Porter was responsible for joint arthroplasty costs within its hospital walls. After April 1st, Porter is now responsible for a number of additional post-acute care costs, which require Porter to take an interest in the highest quality care that is cost-effective. So there's really an opportunity to figure out how to deliver the best quality care at the lowest cost. There's a real urgency to kind of figure out what the best balance is in terms of cost and quality. So this scale depicts kind of that balance between cost savings and quality of care. And listed on the left of the seesaw are the post-acute care services that cost money, so a variety of different services. And on the right are factors that directly or indirectly are linked to reimbursement. So for example, complications can lead to readmissions, and patient satisfaction is strongly influenced by patient outcomes. And so there's a delicate balance to be kind of considered here, because when you consider the service costs in the new bundle, there are a number of ways that you could potentially cut services and save costs. And so many systems are indeed making such cuts, but they're doing so blindly without any knowledge of the implications of such cuts. And the implications are important because they may compromise quality. So if patient satisfaction scores are linked to outcomes and payment, and complications lead to readmission penalties, those things can kind of tip the scales. So if you cut SNF costs too much, or you cut outpatient or home health, you may see an increase in readmissions and a decrease in patient satisfaction if these decisions and these cuts are not informed by information that tells us exactly what we should be doing with patients, more in a data-driven approach. Currently, most clinicians will tell you that it's gut instinct that determines what some of these decisions. And so there are very few data points that drive some of these decisions. And so I'll remind you that our proposed center seeks to address this changing and challenging landscape. We have a way to positively impact patients, providers, and financials. And I'll remind you of our vision to develop this performance outcome center, which would allow us to formulate a comprehensive patient database, which would then allow us to develop some prediction analytics that are very unique, and again, better specifically identify what patient needs are. And we'll go into a little bit more detail in a minute as to what that really means. And the goal of this is to truly revolutionize the patient's experience, optimize outcomes, as well as reducing costs. We understand that you need to take care of patients and accommodate providers, but you also need to make money. And thereby really distinguish CJR as a national leader in arthroplasty and a pioneer in personalized medicine, as I mentioned at the beginning. So develop this truly unparalleled reputation for personalized medicine, be a leader in the field. So let me walk you through what this would look like for a patient. So Hal goes to a local hospital for consultation regarding an anticipated knee replacement. He spends 30 minutes waiting in the waiting room. He gets to spend 5 minutes with his surgeon, who focuses on his radiographs, but does not provide a lot of additional information. And he's offered a cookie cutter total joint replacement pathway. Now Hal comes to Porter, to the Colorado Joint Replacement team at Porter Adventist. And he walks off the elevator, and he's coming for a second opinion. He sees the state-of-the-art testing facility as he enters the CJR waiting room. And he is offered an opportunity to undergo a comprehensive preoperative testing session in this state-of-the-art testing facility to assess his mobility, his functional performance, so including balance and walking abilities, his muscle strength, and the activation of key muscles that we know affect recovery after knee arthroplasty, as well as some biosocial factors. And all these things highly predict recovery after surgery. So the specific things that he's being evaluated on are very much linked to things that we know are related to postoperative outcomes after surgery. In addition, he also receives some cutting-edge assessments that include inflammatory factors, genetic testing, and innovative imaging, which are currently being developed here in collaboration with the CJR surgeon team. And these may be powerful predictors of future recovery. So we're building off of things that we know predict outcomes, as well as developing tools that may further enhance our ability to predict outcomes down the road. Hal then discusses his care with his clinical team, and his care plan is adjusted to his individual recovery trajectory. So what we expect and how he will look very uniquely tailored to his individual needs. So based on sophisticated analytics, we're able to predict how someone with Hal's comorbid conditions, baseline functional status, and risk of hospitalization are likely to contribute to how he does after surgery. In fact, we're able to develop kind of what the expected range might be for Hal. And his assessment reveals a number of important findings, including that he's at risk for a higher post-acute care utilization, such as a need for a skilled nursing facility, and he's at risk for rehospitalization without some preventative measures. Importantly, his leg strength and mobility tests allow us to more sensitivity to detect his risk for rehospitalization than the current methods available. And so he discusses his unique situation and goals with his surgeon, including an emphasis on more preoperative strengthening and postoperative planning for additional caregiver support after surgery. And Hal's recovery is then monitored and adjusted to ensure optimal outcomes based on his unique needs. In fact, because of these preventative strategies, Hal exceeds expectations early after surgery. So you can see the green line. Well, I need to get rid of that gray line. But the green line shows that he actually is doing better than what was expected, kind of in that pink range. So he has exceeded expectations for someone with his comorbid conditions and baseline functional status and all the things that were specifically measured to develop the analytics to predict how he was going to do after surgery. And typically, it's hard and it's very, very difficult to decide when a patient needs therapy and how much they need. So what's done right now is we default to a standard of 2 to 3 visits a week for 6 to 8 weeks, regardless of how well a patient does, whether they're above or below an expected range. And so most patients would be getting this prescriptive approach because we really don't have any other way to make decisions as to how much therapy someone should get. So whether you're 85 years old wanting to be independent in the community or 50 years old wanting to return to mountain biking, you traditionally get the same care and the same number of rehabilitation visits. However, with this prediction model, the clinical team is able to monitor Hal's recovery and direct resources to his needs as he recovers. So giving Hal better care, longer care, but saving resources for when they're needed. So in other words, we're able to stretch out some of those visits and provide additional assistance to Hal to allow for a better overall recovery in the long run. So not surprisingly, when Hal talks to his friends about the course of care after surgery, he realizes exactly how unique this personalized medicine approach is, and he continues to spread the word to his neighbors and friends about his positive surgical experience. So hopefully it's clear as to what an opportunity this is from a patient standpoint, from the example that we've provided. But there are also a number of opportunities for providers. And so one of those opportunities lies in the objective data that's available to assist with real-time patient decision-making. And this allows for the highest quality of care for every individual patient, which is something that providers are certainly very focused on and value tremendously. Not to mention that this database allows for a surgical center for ongoing surgical studies. The research that we've been working on The Outcome Center would support ongoing surgical studies. And right now, patients have to drive from Porter all the way up to our campus at the Anschutz Medical Campus in order to participate with most of our studies. And so this would allow for tremendous increases in productivity and opportunities for the existing and future studies. And that would then, again, contribute to kind of a national level of visibility and reputation. We also have a strong track record in grant funding, and so this would also allow the center itself would facilitate future opportunities for additional funding to support some of these research initiatives. And then very importantly, there's a scalability to other centers within Centura or CHI. And that means that, you know, we could take the successful product and the successful example that's provided through through CJR and Porter Adventist, and provide additional opportunities for the rest of the Centura system and a lot of visibility with this prototype. So from opportunities for growth standpoint, many of our estimates that we're going to share with you haven't even begun to include the benefits of the marketability kind of factors that come with this type of initiative. So this is something that really truly would set Porter aside or set Porter ahead of everyone. And so that visibility is certainly something that will very likely increase the marketability of an increased volume of the Colorado joint replacement practice. And so it would also, as I mentioned before, provide greater visibility and allow Porter Adventist and the team at Colorado Joint Replacement to be a leader in the Centura system, as well as the bit larger CHI system. And the other thing we haven't even considered is the potential for other payment streams. So we could envision patients wanting to have a private evaluation, whether they have knee osteoarthritis and are ways from having surgery, whether they've already had surgery, maybe with a different provider, whether they want to see how they're doing years after surgery, just follow their progression. There may be opportunities for patients who have an interest in getting such complete assessments as private pay evaluations. So really, this is the tip of the iceberg, since we haven't really factored in some of these additional opportunities into our cost savings and our models, projections as to what resources we'll need and what cost savings and revenue generation may be possible. And then one important opportunity for growth is risk stratification. So as I mentioned earlier, we don't really have data to drive our decisions. So we don't really know, most of the time, you know, it's a gut feeling and an instinct that's driven by observing a patient, certainly considering all the relevant factors, but we don't really have data to support some of those decisions. And so from a risk stratification standpoint, we would be able to more accurately model the rehabilitation needs of an individual patient, feel more confident when we're making a decision as to whether we would send them home or to a skilled nursing facility or maybe directly to outpatient therapy. And so there'd be tremendous cost savings that we anticipate from just refining the rehabilitation process. We have 15 years of experience in this field in developing protocols and rehabilitation programs that could really be used to educate the clinicians that you're partnering with, the systems that you're partnering with, to refine the rehabilitation process. And the innovation of the functional data that is part of this center is really important to emphasize, because very few people are collecting functional data. But yet functional data and functional status is strongly linked to a number of factors in terms of mobility. But in particular, it's linked to unplanned readmissions, and that's certainly a buzzword and a hot topic right now. And this is true in a lot of different patient populations. And so it's much more sensitive than some of the other approaches that are being taken to detect change early and really be able to predict potential problems. So really the time is now. There's really an impetus to move very quickly and to capitalize on the opportunity to be at the center of the stage and really make sure that Porter Adventist is at the leader of this particular initiative. So I'm going to turn this over to Andy, and he's going to talk about the costs and deliverables that are associated with this.
Yeah, so the question is, Who do we plan to do this for? And as mentioned, what we envision is doing this on all patients undergoing total knee arthroplasty, because this would allow us to have data as rapidly as possible to start informing our decision making. We have detailed estimates for the investment that's required and broken down by personnel as well as equipment costs and things like that. But what it amounts to is between $400,000 and $500,000 per year. However, based on our conservative estimates of what we think can be saved using these data, we think this amount, by sort of shifting our post-acute rehabilitation strategies and care processes to shift about 25% of the patients into sort of lower cost post-acute rehab strategies. We think that this will save about $500,000 per year once we have it up and running. So we anticipate about 2 to 3 years before the center pays for itself. And then, what do you get for this? What we're proposing is to basically build this comprehensive data collection protocol and put it in place, as well as, what we want to do is actually implement some evidence-based rehab strategies in practice as well. So, and then of course, what this would fund would be all of the equipment that's needed to run the facility, the personnel, all the things that we use in our testing and things like that. As well as we hope to, or as well as we plan to use our resources here at the university in terms of the access to our database resources and things like that. So if we start on this, what we envision is that within 6 months we can have the center up and running, and then what we need to do is accrue enough data to do some of these prediction analytics, and that we anticipate would take about 2 years to get the sample size needed, which would be 500 people sort of through their post-operative recovery before we could start sort of looking at that from an analytical standpoint. So just a breakdown of our estimates of what we think we can save by shifting rehabilitation strategies. So this is our estimate of what we think is being spent on post-acute rehab for all the patients undergoing total joint. And these estimates are based on the CMS data that we worked with Kristen and Ryan to look at. And and one thing we learned is that these data are not necessarily as accurate as we would like. So one good thing about the center would be that we can start really monitoring the data in real time for the patients that are coming through Porter and Colorado joint replacement. But our best guess is that it's about $7 million per year on patients in post-acute rehab. And what I mean by that is skilled nursing facility costs, home health rehab costs, as well as outpatient therapy costs. So those are the things that are built into that estimate. Our best guess is that about a third of the patients are in the Medicare bundle. And so that would amount to about $2.3 million per year that's sort of captured in that group. And if we are able to shift just a small proportion of the patients who are currently going to a skilled nursing facility into a lower cost rehab setting based on some functional data that we think could help with that, as well as if we're able to reduce the stay in outpatient therapy by about five visits on average, then we think we can save about 25% on the of post-acute rehab costs, which would amount to over $500,000 per year. And then for comparison there, this is what we estimate the center will cost to run on a yearly basis, more or less with the personnel and things like that. Now, this is based on if a third of the patients are in the Medicare bundle, but we anticipate that will grow over time to a larger proportion. These bundled care structures are probably only going to become more prevalent. And so if we look at the estimates, if assuming 50% of the patients are in the bundle, then clearly we save even more with these strategies. This wouldn't include things that we think are possible in terms of revenue generation, from the center's marketability and things of that nature as well. So we think our best guess is that this is a conservative estimate of what we can achieve. So why Porter? Well, we've had a successful track record of research and collaboration with the surgical team at Colorado Joint Replacement for about 5 years, and it's been a really rewarding collaboration for us, and we want to take it to the next level. The team at Colorado Joint Replacement has demonstrated consistently dedication to being innovators, to improving patient outcomes, and they clearly do a very high volume of surgeries. So this is an ideal setting for exploring some of these predictive methodologies that we're interested in as well. A brief summary of the timeline here. So if we break ground and tomorrow, what would end up happening is we would immediately start looking at how can we work testing into the procedural logistics of the clinic flow. So how would scheduling work and things like that. And we've already talked with some folks about when that might best fit in the plan of care and things of that nature. We would start training of the testing personnel and the data collection personnel shortly after, within the first year. And then we'd also start looking at who are the most where are the most common referral destinations for post-acute rehab. And we start building relationships with those centers so that we could start to standardize care in those facilities. We anticipate being able to begin evaluations on patients prior to surgery within 6 months, and then we would start to implement our sort of best practice guidelines in all these post-acute rehab settings as well. So we would start working with these clinic settings and in terms of our specific rehab protocols and evidence-based strategies. And then we anticipate accruing enough data to start working on our prediction analytics within year 2, with the goal of having some initial software applications ready by year 3. And then we anticipate a sort of a rollout and a testing and an iterative process of refining those before they're ready for full implementation in year 3. So I think with that, sort of a summary of what the specifics of what we have planned, and with that we can probably take some questions.
We recognize that each person attending is going to have is wearing a different hat and seeing things with a different lens. So we have a variety of different additional slides that may be useful in addressing some of the specific questions that you might have.
Great.